So we're here to just have a general overview, brief kind of talk with demonstration as far as indirect methodologies are concerned. I'm going to take a look at this kind of in a broad sense. So when we talk about indirect, we're talking about indirect barrier methods. So generally, as far as definitions are concerned, working indirect means taking the body part away from the restrictive barrier. And if you look at the AACOM glossary of terms, which I will put the definition below the video, what it's essentially suggesting is that you're taking the body part away from the restrictive barrier such that tissue tension is then equal in all planes. Now that being said, that definition doesn't necessarily tell you about the actual experience of working with an indirect methodology. Working with an indirect methodology, we can talk about the restrictive barrier, and usually when we do that, we're talking about the bony diagnosis, right? So if the knee, like we just speak about the knee, if the knee happened to be flexed, right? Essentially, so just so as a visual, the knee is flexed and it will not fully extend, right? The knee will only go to there as a hypothetical. Then what we want to do, so the restrictive barrier is into extension, we want to take the knee away from extension. Now when we're doing that, again, the bony diagnosis being flexed, so knee looks like this. So that's essentially the bony diagnosis. In order to have tension removed, so we need to worry about that word tension, tension equal in all planes, what we're really trying to feel for is we're really trying to feel for soft tissue tension. So we need to be monitoring the soft tissues in the area. Now, if we speak about the knee as our hypothetical situation and the knee is flexed, that would mean, in all likelihood, not absolutely all reality, that the tissue that was shortened, the tissue that was responsible for keeping the knee in this position, is going to be the hamstring mass. So in a situation like this, what I want to be doing, right, so I would, essentially it would look like this, like test, it wouldn't go, right, it wouldn't go into extension. So then what I'm trying to do is move away from the restrictive barrier. Now you'll see that I need to be monitoring the hamstring. So again, in a hypothetical situation, what I'm going to do is I'm going to work on this as if the patient's knee actually wouldn't extend. Now in this case we know that it will because we saw the patient's knee flat, right? What I'm going to do in all planes, right? So I'm going to start to search for something. Now you can see my hand under here, monitoring the tissue. I'm going to come through here. I'm looking at my planes, right? So as I pull the knee towards me or the foot towards me, I get some softening, get a little bit more softening. Now in a situation like this, to be smart, I can use the table, right? See how I put the patient's foot down? Now I have essentially more contact. So we talk about patient positioning. The table makes stable, less stable means I need to make the patient stable. So if I'm holding the patient up here and manipulating all over the place, then I need to do a lot of work. But if I put the patient's foot down on the table, now I can start to manipulate this lever. Right? So again, we've got sagittal plane, coronal plane, or you can call it transverse plane depending on how you want to orient yourself. But I've got some general softening. I'm monitoring the soft tissue here. Now I can create, if I control, see I wanted to create compression and it wouldn't do it because the patient's foot slid. So what I can do now, this is just me working through the process of how to find an appropriate hold. If I block here, then the patient's foot isn't going to slide. Now, what I'm going to do is I'm going to use compression, distraction, right? So the distraction is me pushing up on the monitoring hand, short lever. So compression is taking the femur and approximating to the tibia, and the reason I can do that in this case is because the patient's foot's on the table. So we create essentially a compression, a distraction, which isn't really going to teach me much because my hand's going to squish into the tissue I'm trying to monitor. But we've got softening, and now because I've got all this contact here, I can start to manipulate through here, right? And also I can manipulate the femur in relation to the pelvis, which also means that I'm going to move the femur in relation to the tibia on some level because I can start to work in the transverse plane with the femur more or less. So we get our softening, and that's what we're looking for. We're looking to position in multiple planes so that the soft tissue gets softer. We need to we consider the bony diagnosis as if the knee is flexed, it is likely to prefer flexion. That doesn't mean that we strictly go on the bony diagnosis. We need to pay attention to the soft tissue. Now, if we look at the varying well-known indirect systems. So facilitated positional release could be considered an indirect system. Strain counter strain could be considered an indirect system. Ligamentous articular strain, balanced ligamentous tissue, or balanced ligamentous tension can all be considered essentially indirect systems. What they're really doing more often than not in application, so facilitated positional release, you're supposed to go to a biomechanical neutral to the best of your capacity. So a biomechanical neutral for a knee, if we consider the anatomical position, we can make the argument that it would be essentially an extended knee. Now it's a bit of a challenge, because in a situation where there's somatic dysfunction or motion dysfunction in a joint, this is not necessarily going to be the biomechanical neutral. I'm not necessarily going to be able to go there. So even in facilitated positional release, where I want to neutralize the joint, we can maybe consider that neutralization going to the point where tissue tension is even in all planes. And then we add an activating force, which would be squishing it together, aka compression, pulling it apart, aka distraction, or torsion, twisting it. Now, what we want to understand is that there will be situations in varying joints where we want to think that when applying indirect methodologies, compression will soften things more. But from experience, from anecdotal experience, from personal clinical experience, as well as the experience of people that I've interacted with as professionals, that's not always the case. That's why they will speak about, say, in facilitated positional release, compression, distraction, and torsion. Now, in strain counter strain, BLT, you are essentially doing the same thing. You're just looking for that neutral spot. So not necessarily a biomechanical neutral, that's preferable, but you're looking for that spot where essentially most tension is off of the joint that you're working on, or off of the soft tissue you're working on. The way you know is because you're monitoring soft tissues. So again, we come in through here and we're looking for that position. We start to move around, trying to find the spot where the soft tissue goes soft, and then we add an activating force. Now in some situations, right, so I can even create a distraction by pulling down here, just as, again, a slight digression as far as technical skills are concerned. That's more or less a distraction, because my hand keeps the femur in the same place, my other hand pulls it away, or pulls the tibia away. Now that being said, we search for that softness, we add an activating force. Now when you're trying to add an activating force, regardless of the system you are psychologically or cognitively attempting to use, what I would say to you is purposely go through an algorithm. Compression, distraction, torsion. Find the one that makes it softer, and then what you end up doing, regardless of which one of these sub-named systems that we're using, you're going to wait. Right? Now, what you will see in some of the systems is essentially 90 seconds or until release is felt, or 90 seconds. Is what seems to have been noticed through clinical experience by various practitioners that has been translated into the literature, is that beyond 90 seconds you get no further benefit for these types of method. Now these would be best considered treatment models, aka they have a way to interpret diagnostic findings, a methodology or a technical application to deal with those findings, those diagnostic findings, and predictable, consistent results. As far as the conceptual models behind all of these indirect systems, the mechanistic understanding may not necessarily be the best, and you can make your own decision if you want to go into literature and check that out. But the big deal here, as far as indirect methodologies, don't simply go away in the direction away from the bony diagnosis. Think about the terms until tension is equal in all planes, aka the soft, the squishy, or to ease. Now to identify ease, you still have to be monitoring soft tissue. So as far as indirect is concerned, you may have the bony diagnosis that you've identified in your own way, but what you need to really be focusing on and paying attention to is that ease. So you have to monitor soft tissues. That's where the concept of broad contact for multi-point discrimination, contact as control, these come together, because you need to be holding a large area of soft tissue around the joint or joints that you're considering, and you need to make sure that those get soft. Once those are soft, you wait. After you wait, you retest. Should you have identified improvement in the motion dysfunction that you found in the first place, then you have an opportunity to move on and continue treating. Should you not have full resolution, maybe that's when you want to consider going and utilizing a direct methodology, or a methodology that goes into the bind, or a methodology whereby the soft tissues in the region of the joint that you're working on have resistance and bind.